So healthcare and the innovation and evolution of healthcare is clearly one of the key drivers for sustainable development. So when we wanted to make this year's conference about sustainability, it was clear to us we wanted to have a panel covering healthcare and innovation in that sector. We managed to assemble a stellar one, and Andrew Trister, who's the Deputy Director of Digital Health Innovation at the Bill and Melinda Gates Foundation, is here to lead it. Take a look.
Great, thank you. Good morning and good evening. I am Andrew Trister, the Deputy Director for Digital Health Innovation at the Bill and Melinda Gates Foundation. I'm really pleased to be here with this distinguished panel to discuss Nordic innovation in the context of health. There's likely no better time to be discussing this than now. As we've shifted this meeting to be online and remote, given the exigency around COVID-19, and so much around digital and health have come into such stark relief for all of us around the world. At the Foundation, we've been focused on enabling better care delivery for those of the least in the world. We see a combination of ubiquitous tools like smartphones, AI, software, and attached hardware platforms as being critical to this mission. I'm really pleased to be here with Philip, Olle, and Andreas from Coala Life, Corti, and ERAS. Over the next half hour, we'll speak about ways that their Nordic backgrounds inform their innovations, how they've approached the problem space around better measurements in the home, improving interface between patients and their physicians, and driving adoption of better protocols in the hospitals with technologies. I'll first ask each panelist to introduce themselves and their companies in a few minutes, and then we can get into the discussion. Maybe we can begin with Philip.
All right, good morning and good evening. I am Philip Siberg. I'm Swedish, and I am one of the founders of Coala Life. It's a medical device company active in the cardiovascular and respiratory monitoring world. I am right now heading up the expansion in the US, so I'm based in Southern California. And what we've developed and have on the market is a digital monitoring solution based on a device, algorithms, and engagement for the patient. So the patient is prescribed with this Coala. The patient typically holds it 30 seconds to the chest, and it captures ECG and heart sounds, which are instantly in real time analyzed and available to prescribing physicians. And we just recently also expanded the use of this to be able to listen to lung sounds on the back. So if you're a COVID diagnosed patient, you can send your lung data to your prescribing physician. All right, thanks.
Great, thank you. And now let's move to Olle.
Hello, good morning, good evening. I'm a surgeon from Sweden. Surgery is a very big part of medicine today, with about 300 million operations done annually around the world, according to the World Health Organization. Now, surgery is also dangerous. 75 million of those patients are going to suffer a complication, and many times completely unnecessarily. Although we've had some fantastic innovations technically with nowadays robotic surgery in many cases, we seem to have forgotten some parts of the care of the surgical patient that is equally important. And that is how we get the patient to recover, to be able to eat, to be able to get out of bed, and to be able to do those things without pain and go home and feeling fine. Now, we started looking at recovery many years ago and started a society and a project called ERAS. That's short for Enhanced Recovery After Surgery. And we got the best people in the world to put together a guideline for us to tell us what we should be doing. They came up with about 20 different care elements that all have an impact on outcome. And together they're equally important to the surgery itself. We then started a software company, NCare, that have put these guidelines into a software that is readily available as a cloud system. This allows units around the world to check their processes and their outcomes with the guidelines so that they can get full control over what they're doing all the time. Now, this has been proven to be extremely effective. And we have now medical reports from all over the world showing that when you're using ERAS, you can reduce complications by up to 50%. You can have patients recover without going to intensive care to the same extent. And many of them will be going home feeling fine after days instead of weeks in the hospital. And recent data also shows that there's an association between enhanced recovery protocols and survival after cancer surgery. So this is now available in more than 25 countries around the world. And we have some of the leading centers in these countries helping us spread it further. We're looking for others to help us spread this so that we can reach just about everybody out there. Now, we believe that the key to success is having the best innovators in the medical profession and the software profession come together and put together a device and a system that is so easy to use that it's going to be used everywhere. And we're just about being there. We just need to spread it. And in these days of COVID-19, with a huge backlog of surgery that never could be performed, and that is just queuing up to get done, and with enormous pressure on the intensive care beds around the world, we think that ERS is more needed than ever before. Thank you.
Yeah, thank you. And now, Andreas.
Thank you. Calling in here from Copenhagen. I represent Corti, which I was a part of co-founding in 2016. We're 50 people, and we've built a digital assistant to listen in on doctor-patient interviews and help triage the patient faster and more accurately. Our basic premise was that we're looking at a future where we lack educated, qualified medical professionals more or less across the globe. And as we see patients becoming more and more self-educated, we increase, of course, the liability profile and the expectations of the patients. And we thought medical professionals could use better assistance, as some of the tools provided historically has been recently pretty outdated. So our idea was building a voice-based service, a bit like you know from Siri, that instead of just waiting for a command, is listening in when a patient is interviewed by a medical professional, and help look at that interview and compare it to millions of prior interviews to see if there's any kind of pattern that can help the physician predict what's going to happen with this patient and what does the risk assessment look like. Right now, we're implemented primarily on 911 and 112 calls. So that's when some of us have an emergency and we need dire help. We try to help the medical dispatcher come up with a conclusion really, really fast, since time, of course, is of the essence, with at least as few mistakes as they're already making. Many of them are very, very good. We just try to help them do it even faster and with an even higher accuracy. So the people who might not have had a chance due to any kind of complication now will actually stand a chance of getting the treatment they need in time.
Terrific. So I would like now to ask each of the panelists to think back to your respective Nordic backgrounds and what values those backgrounds have brought to innovation for you in each of the problem spaces that you've been focused on. Perhaps we could begin with Andreas and hear about this solution that he's been describing and learn more about how this might have fit.
So I think first off, coming from Denmark and Copenhagen and having lived in the US out of San Francisco, I've seen the best of both worlds. And I think what we can offer from Scandinavia is at least a different view on what support the patient can expect through their journey. We're all patients at some point. And I think what we're trying to accomplish here is that we're layered within any kind of interview, a physician would deduct what is the most important thing to act on. And that, of course, stems from communication. And communication is global. It's increasingly complicated and very much bound by the context of the interviewer. And I think that looking at that kind of complication coming from a small country with only 5 million people speaking a language many would find very weird just to listen to, we have to build basic skills within understanding language and actually compiling it. And we come from a country where we expect the best care possible at any given point in time. So the basic idea of taking that expertise that's anchored inside the context, inside the education, inside our society, and actually cherry picking that in language in real time and giving cues to what that might look like in a risk profile, I think builds a lot on the premise that coming from Copenhagen, we have a hard time finding that one patient across the globe might have actually the same symptoms as I have, but I have access to much better expertise. And that's exactly what we try to democratize. And I think that as a word is something that stems deeply with Scandinavian roots.
I think that resonates deeply. And I'm curious, Olle, if you could to speak on to the same thing, because it sounds as though your background on ERAS has approached the same problem space.
Right. Well, the whole idea came up when I started working with a colleague from Scotland a few years ago, and we got together with a few other colleagues from Northern Europe, and we realized that there's a huge variability in what is actually being done out there, and there's no control over the entire process. Everybody's doing their own little thing along the journey that the patient is making. Now, of course, Sweden is, like many of these Nordic countries, a very equal country, so we're not afraid of delegating and giving people the possibility to take control. And I think that we then sort of reached out to the sort of the core of many of the people working in medicine. We all go to work to actually help other people recover, or with the treatment. That's really why we've chosen this job. So by sort of addressing that specific one and helping people to see what they're actually doing, but giving them the control. So this is all done at the floor, where the people, the surgeons, the anesthetists, the nurses, they all get together and they do this control measurement and follow their data all together all the time. They have the control over the entire situation. And that actually has been very stimulating for them, because as soon as they know what is not functioning, they will start to address it. You don't even have to ask them. And once they start to get better compliance, it's been showing for everyone, and not least for the C-suite, for the people in the management. So all of a sudden, here's a group of people on the floor actually delivering what the management have been trying for a very long time. So it's opened up a lot of communication between the people that didn't speak that well before, and that has also helped to spread within the hospital. So I think that this idea of not being afraid of giving it away and giving people, empower people, and giving it to them, I think that's from our heritage, I think, quite a lot, and that's been good for us. And the interesting thing is it works everywhere. You don't have to be Nordic to do this. It works just as well in the Philippines or in the United States or in Latin America or even in Africa. So.
Yeah, absolutely. And I'm curious, Philip, to hear your take on this too. The approaches that you've been taking with Coala Life are, the regulatory hurdles that you have to overcome, just as, well, at least with relation to a medical device. And I'm wondering if there are specific elements regarding the heritage that you would want to emphasize from what you've heard from the other panelists, but also other aspects that you would like to highlight.
Well, I share a lot of the things that have been said. Our mission as we started was to democratize cardiology and really kind of help to target the leading cause of death in the world. And I think the Swedish heritage has been strong because we're good at innovation, we're good at being experts, but it's a small country, so we're dependent on international affairs. And I think what we've done is using the Nordics as our learning and breeding ground. So that's where we train our algorithms, so where we learn from usability from the early adoptive Scandinavian community. And then as we bring this out in the world, we're now in Germany, the Netherlands, the US, and soon Japan. We're coming in with a solution that is always targeted towards the individual, which in the end is always the end customer in healthcare. And so I think these things have really tried to change. And we had a huge hurdle in the regulatory. We were one of the first companies in Europe having a medical device system consisting of so many different aspects in this digital space. And then we could use the data set from the Nordics as we went to the FDA and said, hey, now we've done thousands and thousands of patients. So FDA, here's real world data. So that was actually the tipping point of getting our US clearances. We didn't have to show US data because FDA trusted the demographics of the Nordics in coming in here. But I'm really proud to be a Nordic, and I think that we're good at design and interaction and understanding the use and the affordability of all this, because in the end, We want to make this very affordable and simple for the patient, and making sure that providers are paid and that ultimately the payers get the most cost-effective solutions on the market.
Yeah, can I add one thing to that? Just a quick one. Just thinking that one of the things that I think is very typical for Nordic countries is we're pretty good team players. We've always been small. But we don't have a lot of individualists. We have some, but we have a lot of people that are actually very keen to work together and listen to others. And I think that comes across for all of us.
I think this is a great point, and I'm curious, how then would you make recommendations for others who are listening to this, who are maybe in other places in the world? What would be the starting point? Would it be the team player aspect? Would it be some of the elements of finding those places where there's more attitude toward innovation? What do you think is the mix that we might be able to translate to other people? Like, what would be the recommendations that you would make to those listening, interested in innovation?
My favorite comment is always, it's all in the team. The rest is just technology and innovation. You can't make it happen without that. And I think you got to focus on, don't get stuck on trying to solve the small problems, and rather, what is the large scale scope you can do here? How can you make a significant change? And that's why I always talk for the Nordics, that sometimes we get stuck in the Nordics. The world is very different outside of it, and you need to be very adaptive to changing to fit the needs in each country out there.
Yeah, I would agree with that. I think that, although we in every place that we've been training hospitals, and we do the same thing everywhere, we're training people to actually work as a team where, in many countries, the surgeon is the king, and that's the guy who decides, usually a guy also, by the way. To have these people to sit down and actually train to listen to the nurses, what is working for them, what is not working. That has been, I think, an eye-opener for many of them. But you still have to allow them to have their own culture in place. But just the mere fact that you can stimulate them by doing that and bringing in top name people, and that we've been fortunate to have those on board, to say the same thing, that, if some of the big professors from the US is coming to people in other countries and saying, hey, we work as a team back home, then other people start to listen as well.
I was lucky enough at some point to get some feedback from one of the greater technology entrepreneurs of Scandinavia, a much smarter guy than I am. And he said one of the beautiful things for him being a part of the first .com bubble back in the day, 20 years ago, was that there was so many vast opportunities by just pushing things online. And I think, as he saw today, we're at a point where a lot of the really, really important innovations at this point might not be as incremental as we'd like. So although it can be very favorable sometimes to look for the next thing to put in an app or put in a service or digitize, to do true innovation at this point, I think you need to rally people around a vision that's worthy. And I think it's not about getting further up the branches of the big tree, since there's plenty of people doing incremental innovation. I think a lot of what's needed in healthcare right now is people taking a big leap of faith. And I think Scandinavia creates an ecosystem, especially in health, where you can go and ask some pretty hairy, audacious questions. You can both get the right people on board, and there is room to ask them. Of course, we don't have the market capacity or market size to actually build companies, billion-dollar companies, $100 billion companies. So we need to push them out the door of Scandinavia. But we have a very, very good sandbox to start building these and ask these questions. And I think that's definitely something we could learn in other environments. How do you create these environments where you can ask questions and iterate on them and build the first early stages, since that's definitely getting through the threshold of just the early stages is so hard in health, in my experience.
Actually, stemming off of that, I'm curious if you have ideas of what is the next thing? Like, where would you want to be putting your focus now, like, that needs the greatest innovations at the moment from your perspective?
Personally, I think access. We still very much need access. And I, for one, as a democratic Dane, have a hard time not feeling that we all have basic access, basic services. I think the beautiful times in history where all of a sudden, when the first light bulb came on in the US, it didn't take many moments to, I imagine at least, to feel that this was a household innovation, right? I think we saw the same with cell phones. So like all of us, why would we have a smartphone? Why would I have my email on my phone? And all of a sudden, like you can't imagine not having it. I think health needs a lot of these moments though. There's so many things we should have access to distributed, and there's so many things that are not distributed equally. And I think the biggest, most important thing we can do, I think like Coala Life does as well, we need to make sure everybody has access. And there's a lot of things, especially in my mind, the expertise to get the basic amenities, the basic advice, the basic expertise that in many places in the world is not even in place and will take many, many years, if not decades, to get it there if we don't use innovation and technology. And I think that's what keeps us up at night, and that's what makes us able to poach talent from much bigger companies and pay them much less, is that we all really dream of a world where the amenities, the light bulbs of the innovation in healthcare is turned on.
Philip?
I mean, I can comment.
Throw the same question your way.
We're my two dream areas is, one is the whole digital therapeutic side and how you can use devices and systems to actually have a therapeutic benefit. And we've done some large studies on, cohorts of 1,000 patients, and proving that by using a device like ours, you can actually improve quality of life and improve outcomes. So you can prescribe device and digital solutions as an alternative to pharma and alternative to interventions. So that's one of the futures. The other one is we're working very much on the algorithm set and how to do predictive analytics in this. I mean, despite what's happening in the world every day right now, 25,000 people every day are dying in cardiac-related disease they did not know they had. So if you can help on a broad scale to early detect these problems, and by that coming in and then helping to treat and avoiding this happen, there is an enormous opportunity out there to help save the world. Those are the two targets for my future.
Yeah, I think what in medicine really what is needed is to be able to perform good clinical studies much faster, much better, and much cheaper. And I think by building a platform where people are recording their data on a daily basis for everything that is making a difference for the outcome, with every patient that they put in, we have created a system that is actually it's a quality registry for all those hundreds of countries that don't have it today, but it's also a fantastic platform for research, and that's something that we're heading into and we're developing right now. So you can just imagine doing randomized trials on data that's already being collected with just the additional questions that goes with that specific trial. You would, and a huge number of units that are on board where we have full control over exactly what's going on in each one of these units. We have a fantastic platform to do research at a much faster pace and much, much cheaper, because it's costing way too much and it's taking too much time. And on top of that, if we have a lot of users on board, then obviously we have a fantastic opportunity to bring the new treatments out to all of those much, much quicker. People are not aware, but it takes 15 to 20 years to actually get a new proven treatment to be standard of care. So, I mean, here's a huge job ahead where we can use modern technologies, just like my fellow panelists have been stating here. This is really the future. But I think it's combining these ideas, new devices, artificial intelligence, and a big platform where a lot of people are involved, and doing it as part of their regular care. That's what I'm hoping for.
Yeah, I couldn't agree more. So following up on that, of course, the elephant in the room is the fact that we're not in a room together. And I am curious about your take on such a platform and on the different tools that you've each worked on and developed in relation to approaches to COVID-19, to this pandemic, and to both to stopping the spread and ideally to getting to therapies and vaccines faster. I think, Olle, this point that you were making is a really important one. I'm curious if you've put some thought into what would such a platform look like, and how could that make a global impact?
Yeah, I think that any complex disease management you could put on a system like ours. We just happen to be surgeons initially, but we're looking at working with oncologists and other pulmonologists and diabetologists and so forth to have their protocols and guidelines put in place. Now, I think for COVID-19, you would probably have to build a platform where, we don't know yet. A lot of unknowns are there. So you would have to just have a way of collecting the data and then use smart systems to analyze that quickly to understand what's actually going on. And you can do a lot of things with data that's collected, obviously. You don't have to do everything prospectively, but you could get a good idea of and do hypothesis generating studies if we had a platform just collecting data, and then use the same platform to do the randomized trials much quicker and much better. So that's definitely a possibility.
Andreas, I'm curious what your take would be on using data in this way.
So I run a machine learning company. So data is the lifeblood of all we do. I think first off, something that's very underestimated in this data discussion is the quality of data. So of course, all data that is hard to access seems to people to be valuable. It's if you can create correlation, that's obviously interesting, but it's not necessarily very important. Whereas causality is much harder. And I think we should be very worried, first off, when people start talking about correlation, and actually what we're looking for is causality. And I think to Olle's point, we need prospective trials, and we need them to be a lot faster, and we need a lot more of them. And I think especially as technologists, so I'm not a doctor, so I wouldn't dare to venture into lecturing on the smarts of the healthcare sector. But I do know one thing, and that is, at least when I talk to smart doctors, they have a hard time trusting a guy like me if I can prove it. And I think that's one of the most important things of the healthcare sector, is that they are not swayed or easily impressed by yet another technologist with a good solution. You should, of course, see data. And I think that's something we have to learn to operate within the realms of medical evidence building, since that's not what's coming out of Silicon Valley these days, right? That's much more about build fast and iterate fast and maybe break some stuff on the way. At least that's what some companies been doing. And maybe that's not where I want my data as a patient. So I think we should be worried, first off, with COVID-19. Yes, it builds a huge push on digital solutions, and we see it in telemedicine, I think, a lot. But this should not mean that we should start selling away our digital rights or the data that actually can create true causality without having that dialogue about what that means.
Absolutely. I think that this is a really important topic. I think, Philip, at the top of this panel, you had discussed the fact that your tool already could be used toward lung sounds as a thing, but I'm wondering if you could address this point that Andreas was making relating to some of the privacy issues that come about. Yeah.
I mean, my initial thought when setting up the company was to use all this data from a very diverse usage group and create one of the largest databases ever on arrhythmias and heart sounds. So we ask every single patient that uses our system if they want to share their data in what we call the Coala Atlas. And approximately 80% of all our users opt in to share their data for research purposes. So we built a database today of, I think it's now way beyond 30 billion data points of data, which ultimately we want to share with the world. I want to go to Olle and to other researchers and say, hey, what can we do with this now to crack the code? So we just announced an interesting partnership with Microsoft and Novartis, where it's called a data collaborative, and really how can we jointly help to minimize the data divide and make this valuable data available to everyone. So we spent too much money on lawyers and thoughts on how do we address this from a privacy point of view, but we simply did it by letting the patient or the user decide themselves how they want to do it. And I think it's very clear that people do want to share their data. And the data says the sicker you are, the higher the probability or the willingness you are to share your data with others to help make a difference.
Yeah, so doctor, I can, sorry, go ahead.
Yeah. No, I just wanted to quickly share that. So on the lung sounds, the beauty there. So we had our first patient started up last week in a rural setting in the middle of the US, probably on COVID diagnosed. And then we could connect in physicians at leading hospitals in larger cities in Ohio, etc., who could then remotely collaborate and review the data then coming in real time from this patient in their home. So I just see the new types of devices, solutions, software, platforms out there, such an enormous ability to connect the world and really join forces to help save a lot of patients out there.
Yeah, I just wanted to add to that. As a doctor, it's paramount that you stick to the ethical rules, and of course, like Andreas was pointing out, it's bad data is not going to help anybody. So you need to validate all the data that comes in, and that's something that we're surely doing. And on top of that, of course, every patient that goes into our data system has agreed to participate. We have about 80,000 now, different surgeries, most of them major operations, and that's really something that I think can grow very, very quickly. And then we can use it for those randomized prospective trials to find the causality that we're all looking for. But it's also good to be able to focus using older data already collected to do the right study. So you can play around with that data to see whether to find which are the hypotheses that might be most interesting to study prospectively. But I think this is all should be coming together. Yeah.
I think a small note on that, I think that is very interesting, is that I would definitely trust you, Olle, with my data, but I think there's also a big buildup on the society and the school of ethics we all stem from, right? So there's just got to be companies, and I think right now we have a geopolitical crisis between certain nations where some of those actors from those countries operate under a different code of ethics, given that their socioeconomic status and other problems keeps creating hassles that we, from a long time ago, has been able to tackle, which they maybe haven't until recently, and that has built a different kind of culture around data. I think one of the things we can build on in Denmark, and I think a lot of tech companies in the US could look at, since we have a lot to learn from US companies too, is at least how do you build a precedence of a long time of very trustworthy behavior. And I think that stems a lot from how can you be proactive into trust. So I think the Atlas is a great example of something you can do proactively. Maybe you can't do most riveting things in the beginning, but when you start diving into it and you build the platform, you also commit to a way of thinking, ethics, a moral around how you're going to look at your data, what you're going to teach your employees about data, and that's what's going to create operational excellence over time. And I think that truly will create trust.
Yeah. I think this point about trust in particular in the system is cannot be overstated. And I'm so thankful for all of you for being here today to share your perspectives and particularly on these last aspects, to talk about how your backgrounds have brought us to this point where we can build these innovative technologies that can impact the more global realm. So I hope that the audience joins me in thanking Philip, Olle, and Andreas for their perspectives, and thank you to the organizers of this forum for hosting us in this virtual realm today. Thank you so much.